Hey, everybody. Welcome back to another episode of Between Sessions with Berries. Our guest today fills a niche that we don't talk about a lot, and we're going to dig into it, but I want to introduce you to her first. I have Susan Frager here with us, MSW. She got sidetracked from her clinical career and ended up working in managed care. And as that was really getting started in the 1990s, and since then, she spent her career operating and billing a credentialing service for mental health clinicians of all disciplines, serving professionals in multiple states. In late 2021, she began pivoting into coaching and training, and as of 2025, she is a full-time consultant, coach, and billing instructor to mental health clinicians, billers, and credentialing administrative staff. Her philosophy is, you don't know what you don't know. I love that so much. You don't know what you don't know. So I'm here to help you learn in a supportive way and try to make it as easy as possible. I'm so glad you're here. You also offer support and intervention for complex claims and appeals. So if you're just like somebody that's like all of a sudden can't get an entire payer paid, you're the expert with that. You'll hop in and figure out how to get this paid. I love that. We need you so much. As well as a membership-based billing resource tool that can be accessed 24/7. Susan is especially known for helping clinicians figure out the labyrinth of Medicare enrollment and billing, trying to decide whether to opt out, and for writing strong dispute letters to top insurance executives that grab their attention and resolve complex, lingering billing issues. So excited to have you here. I could just probably have 17 episodes with you just based on that bio.
Well, I'm willing. Thank you, Kim. Thanks for having me. And I'm willing to do 17 episodes, maybe not back to back, but
We'll definitely need you as a recurring guest for sure.
Thank you.
Thank you for being here. Really, today, the topic we want to talk about is provisionally licensed clinicians. This is a huge topic that comes up all the time. Like, what do we do with the provisionally licensed, especially if you're running a group practice and you want to be working with these clinicians, helping them get, licensed and all of that? Let's dig into it.
That is a much needed topic.
Yes, it is.
And I'll be honest, I'll do a little bit of promo off the top.
Let's do it.
I'm doing a webinar on this on July 17th. Hopefully Kim will have all the registration details in the podcast notes.
Yes.
But it's probably after Medicare, the number one question I get is, how do I bill for this? Is it allowed? How do I document it? How do I even know? Because, of course, not all payers do the same thing. That would be too easy, right?
Right. Oh, my gosh. Wouldn't that be nice?
Yeah.
Let's define what provisionally licensed means, because I know there's a little disconnect there, too. Like, is it an intern? Like, what level are they in the process?
That's a great place to start, because people use different language. I've found that a lot of it's regional. So I'll try to use different words to mean the same thing, just so I don't confuse people. In my way of thinking, an intern is somebody that still is in their graduate program, not somebody who has a master's degree. Now, I know that in psychology, it can be a little different, because psychology has postdocs where it's kind of, I think, all but dissertation. I don't know. I didn't make it that far in my PhD program. I was like, nah, I don't think dissertation. I am good. So that's why I got the MSW. So for the master's people, if you're doing your internship, your practicum is what we called it in my graduate program. That is not supervisory billing. That is typically covered by insurance. Mm-hmm. What is sometimes covered is after you get your master's degree, and in the 2 years or 3,000 hours or whatever your state requires, where you have a license, but it is a license to practice under supervision. I know out here on the West Coast, we call them associates, but I know that term isn't always universal. So I try to be real careful, provisionally licensed or, requiring supervision. There are, I don't know. I mean, every time I work with somebody in a different state, they say, oh, no, we call it blah, blah, blah. And I can't even keep it all in my head. So
it is confusing, because even in, I've got a Facebook group, you and I have talked about this, that talks about billing. And in there's like so many different terms. We can't even agree on like what type of billing are we actually talking about here, to be able to give information to help people in this process that you're going to teach us about today. So this is a huge question. What do therapists need to know if they want to bill for provisional licensees? in their practice. If they want to bring these people in, help them get licensed to that point, what do they need to know, like to get started if they want to start billing for this particular person?
You need to know a lot. And since we started
Yeah.
by defining terms, I'm going to define another term that people use incorrectly all the time, including and especially the insurance companies. And it's called
Yeah.
incident to. You've heard that
Yes.
term, right?
Yeah.
Okay.
I even use it sometimes by accident.
Right. And I have a blog. It's by the SEO numbers, it is the one that people hit on the most and link to the most. And it's from a couple of years ago. I probably have to see if I shouldn't bump it up, even though by date order, it's kind of way down on my website. It's called Incident. I forget the exact title of it, but it was basically how incident to is not the same thing clinically as supervisory billing. And in this minute, while I'm talking, I'm wearing a very clinical hat. We're not talking about billing right now.
Okay.
Incident to, if anybody has, and this is kind of an aside, it's like the generations are really different. And when I say generations, I mean generations of clinicians, like when you came through the system, not your chronological age. But like for somebody like me who graduated in the early 90s, I mean, we had to work in hospitals, community mental health, whatever, or, substance abuse treatment. So when I say the treatment team approach, I know what I mean, but I know that there's people who go right into private practice, and I say that to them and they're kind of like, huh? And I'm not here to pass judgment on it. It is what it is. But if you think about it, incident to is the treatment team approach, the classic, you're working in a multi-specialty team headed by typically either a medical doctor or a psychiatrist, who that person is doing the billing and you are. And incident to is very much a Medicare term. It's defined by Medicare. So, I mean, I don't personally like that term, but, I don't control CMS. They say your services are incident
You
to,
don't.
right, the psychiatrist. And the psychiatrist is the treating clinician of record, not you, under incident to. Your services are just part of the overall treatment plan.
Right.
So what part of that clinically looks like billing for a provisional licensee, where the provisional licensee is going to do the assessment session, not the supervisor, and just having the supervisor do the assessment session, I'm sorry, that still doesn't make it incident to. People think it does. It doesn't. From the client's perspective, it is the provisional licensee who is their therapist, not the supervisor. I mean, yes, the client knows that this person is getting supervision, and they might have met the supervisor, but the client thinks the provisional licensee is the supervisor. Okay.
Right.
The
yes.
provisional licensee determines the treatment plan, and the supervisor is basically just a case consultant. So clinically, these models are very, very, very different. And I'm going to throw shade on insurance companies right now.
Please do.
They use incident to wrong. Probably because the people that are writing these manuals are not billers. They're just, and they're not clinicians. They're just executives somewhere who are like, oh, well, okay, Medicare, incident to, blah, blah, blah. All right, we'll put it in here and call it incident to. And it just confuses everybody. So that's kind of where you have to start with supervisory billing, is because getting started with it means finding out which insurance companies allow it. And I'll tell you how not to find that out.
Yeah, that'd be
Pick up
good.
the phone and call. Do not do that, please. You know what happens when you pick up the phone and call, right?
Oh my gosh, yes, that's a nightmare. Right. And then
After
you're
40
using terms that they're not using, and it's like nobody even knows what you're talking about. And
And after
oh my
45
gosh.
minutes on hold, you're getting somebody on the other side of a big ocean whose first language isn't even English, much less understanding complex clinical terms, and they're reading from a script, which that script has to cover all specialties, not just behavioral health, and they don't know. And a lot of times, I mean, these people in call centers are graded on resolving calls. So their goal is to resolve your call as quickly from, the minute the person comes into your headset to the minute you hang up, that's call. And they're monitored on how fast they can resolve calls. And they don't really, resolution is just a matter of talk time. It's not,
Right.
is the issue really fixed or resolved?
Yes. And how are they even going to understand it when their own company can't even agree on what the term means?
Thank
You know,
Yes.
like, I mean, it's so what do we do? Let them, we're under agreement. Like, don't even call. It's
Don't
not
waste
even
your
worth
time
it.
calling. It's in the provider manual, and they come out about once a year, sometimes every 6 months, and there's no way to find it easily a lot of times. You just have to comb through it. My preference is if they allow you to download a PDF. And then what I do is I'm a Windows user, so it's Control F. I don't know what it is on
I was
Mac.
going to say Control F it.
And I just start putting in keywords. People are like, how do you find stuff so quickly? It's like Control F, you know. Lately, AI is getting better, and I know you're the AI expert, so I don't want to say too much because I am not an AI expert, but lately I've noticed AI seems to be getting better at, so if you ask one of Claude, or there's a million of them, ChatGPT or whatever, does, insurance company cover. I think the thing with AI is you have to make sure you define your terms very carefully. And then don't assume the AI is right, but it can be a really quick way of getting to the manual. And then you can link out from the AI to the source. And I always ask AI for a source. Give me a source. Yeah, if you have any other tips, let me know. I mean, I'm still learning AI.
I mean, that's totally, I mean, I would upload the PDF. If you can get a PDF, upload the PDF to it and, use it as a source document to be able to pull that information too. Yeah.
Yeah. Unfortunately, some insurance companies are getting smart and they're not doing that because they don't want people distributing it. So then what you have to do is you have to go through the HTML, and that's so much slower. It's like,
I mean, this is like total side note, but I do use a browser called Perplexity. It's Perplexity Comet, and it has an assistant on the side that can take over my screen and do all the dirty work for me. So I've literally, probably for something like that, if I couldn't get it, I would log in and have my assistant on and tell it to go do the work and search the doc and come back and report to me. That's probably how I would do that.
I didn't know Perplexity had a browser. I've heard it's a great AI tool, but I didn't know it had a browser. I'm going to check that out.
Comet is the name. It's amazing. It's
good to
really,
know.
truly amazing.
Comet, like in the sky?
Yeah, like
Shooting
a
star?
comet. Mm-hmm. Yeah.
Good, thank you. Yeah.
You're welcome.
I mean, I was looking yesterday at a TRICARE thing, and TRICARE has it that way, and I was looking to find out if you could bill a no-show to TRICARE, and oh my God, it took me like 30 minutes, and I was just...
Oh my gosh. Try Comet. Get the Comet browser.
Yeah, exactly. Okay, so the provider manual tells you everything you need to know.
Okay.
I mean, for the big companies, I can tell you the big three. Cigna, yes. Of course, they also don't. They pay the worst in most places.
Yeah.
Aetna.
Oh gosh.
Yes. And now United Healthcare is really weird because in a few states, state legislatures have passed laws because of access issues saying we expect coverage of provisional licensees. So in those states, if you're in network with United, they will allow you to bill supervisory regardless of a special contract. And I think it's California. I know California is one. I know Iowa, Massachusetts, and I'm always confused about the fourth, and there might be a fifth because I think Illinois may have passed it, but it's not yet.
Did you say Ohio? Yeah,
no,
okay.
not Ohio. Iowa?
Oh.
Iowa,
maybe.
Massachusetts. Iowa, I know, is one. Massachusetts, California, and anyway, I haven't.
Yeah.
It's 4 or 5 at the most states, but here's where it really gets complicated. Only for commercial clients. So you have a Medicare Advantage client, forget it. Medicaid depends on your state. So it's like you have to know the type of plan you're billing, and that is one of the biggest ethical issues with supervisory that comes up all the time is what if you get that wrong and you place a client with a supervisee, but now you can't get paid for it, but there's this clinical relationship that's been established. What do you do? That's one of the biggest problems.
Yeah.
Yeah.
What do you do?
Most
Find a new
people,
clinician, transition care,
you
I guess.
know, outside of Medicaid, most people offer a choice. They say, we apologize. We found, we got it wrong. Sometimes they can make a case at the insurance company because the insurance company makes it so darn difficult. If they absolutely can't, it's generally, reduced rate, self-pay, or, move to a licensed clinician, a fully licensed clinician, and then that, of course, is kind of up to the client, and you provide transition sessions and all that. Keep in mind that, like, if you are going to dispute it with an insurance company, don't even bother if it's Medicare Advantage. You won't win.
Okay.
Because CMS guidelines are very clear. There is no supervisory billing. There
Yep.
is incident 2, but again,
Oh my gosh.
but you have to have the clinical model of incident 2 that I just described documented in your notes. And if you're a master's level clinician, you cannot be the clinician of record. It's only psychologists, I believe nurse practitioners, and psychiatrists. So forget about it if you're a master's level clinician.
Wow. Oh
It's
my
crazy.
gosh.
It's just insane. So everywhere else with United Healthcare, you have to have a contract addendum that allows supervisory billing, and they don't make it easy to get. They won't even give it to you unless you're a big enough group. Please don't ask me what big enough is, because it seems to depend on the phase of the moon, the tides, what state you're in, how nice you are to the person. Did they get up out of the right side of the bed in the morning? I mean, I don't know. I've heard everything from 3 to 30. And sometimes only if you're multi-specialty, like only if you have a prescriber on your staff. I just don't know. That. And then in order to actually get, if they say you're big enough, I believe the next step is they actually pre-audit your documentation. And then you have to pass that before they'll give it to you.
Yeah. Yes. Oh my goodness.
Which, I mean, I do like to bash insurance companies, but I will say there's one good part about that with United. And that is at least because Cigna and Aetna, they're playing an evil game. There's 2 ways to bill supervisory. One way is where you as the licensed clinician, it's as if you saw the client and the supervisee appears nowhere on the claim. That is how Aetna and Cigna want you to bill it. There's a problem with that. And the problem is math. Think about it like this. Insurers use AI. They've used it for years. And there's something that billers refer to as MUEs. It stands for medically unlikely edits. Okay.
Wow.
So if you're a group of 5 and you have, let's say, let's move the math a little bit. Let's say you, Kim, have 4 supervisees. And they all see 2 Aetna clients a day. Okay, so 4 supervisees times 2, that's 8 clients. And then, Kim, let's say you see 3. That's 11 claims with your name and NPI going in on the same date of service. And that MUE, the medically unlikely edit, is going to be flagged. And it basically says, BS, Kim could not do 11 sessions in one day. And then that's an audit trigger. And so it's almost like, I feel like it's setting you guys up. Whereas, I mean, United is being jerks about it and not opening the door, but at least you're not being set up for clawbacks.
Yeah, right. Exactly.
Yeah.
I mean, even if they come and they do the audit, right, and they see like, oh, okay, I see your documentation that you're signing off on these supervisees' notes or whatever. The time involved in that, like even having to deal with that is just, oh my gosh, exhausting. And then God forbid you get into their cycle where they're just like you're on their radar now, right?
Exactly.
I would imagine that's terrible.
Exactly. So one of the biggest pieces of advice I can give people who want to get supervisees on board is keep the numbers small, like 3 or fewer per fully licensed clinician, and make them as part-time as you can, or maybe do it in such a way where you are only seeing self-pay clients so that your numbers don't go into that total, and keep those numbers small. It's a setup.
It is. I mean, everything the insurance companies do feel like a setup to me.
I agree.
I mean,
I agree.
gosh, it's so awful.
And what I always tell people is, here's the setup reason. Because they can claw back, but they can't turn back time and undo the fact that you provided service to their employee, which, if they successfully claw back, is now a free service. And so then the CEO can buy his 5th yacht.
Oh my gosh. Oh my gosh.
That's how I think of it. You know?
It's true. Yeah. I mean, that's legit. And I've always heard that, like, I mean, I don't know if this is a rumor, but I've always heard, like, they just deny 10% just because. Just, like, that's, like, their status quo. Is that a myth? I mean, I've totally heard that before.
Well, I mean, I can tell you from my time working at Magellan, it wasn't. But then again, that was back in the dark ages when AI didn't actually look at claims.
Yeah.
When a actual person looked at claims. But then again, I only worked for one insurance company for a very short period of time. I can't say what it was like.
Yeah.
For every insurance company. But into the age of AI now, it's totally a matter of kind of like dial and denial. And by that, I mean, like, have you read any of the ProPublica articles that they came out with a couple of years ago?
Some. It's kind of off my radar lately, but yes.
Okay. Well, some of those articles that they came out with in, I think, 2024 talked about they can adjust the AI to be either more lenient or more strict. And they do, and they can. For instance, I'll give you an example that is more for like the nurse practitioner crowd. Aetna and Cigna both have automatic downcoding rules now. And what that means is if they bill a level 4 or 5, which is higher intensity, higher reimbursement, they're not going to deny the claim. They're just going to downcode it to 992 and 3 and pay you at that level. And then if you feel like your documentation supports a higher level, it's on you to go fight it and initiate the appeal. And what they're doing is they're counting on the fact that like 98% of people don't appeal.
Yeah.
And I am now hearing that United is doing that for 90837. I'm starting to hear rumors about that. I don't know if it's true, but I've seen it in like on social media. So for what that's worth. The other thing is, keep in mind, is and this is going to sound really, really paranoid, but they do keep profiles on providers.
Oh, I believe it.
No, they do.
I believe
They
it.
do.
Yeah.
And believe it or not, standing up to insurance companies and showing them that you understand the way the game is played makes them less likely to mess with you than if you just kind of roll over. It's really true. I should come back for another podcast just on provider profiling.
Oh my gosh, you should. And then your strongly worded letters on how to deal with them.
Exactly. And that's just it, is they can adjust the AI by tax ID and NPI. So for some people who routinely have problems, it's different than for some people who have very few problems.
Right.
Yeah.
Oh my gosh. Yeah. We've got multiple episodes here.
So back to
I want to
supervisory
get
billing.
back. Yeah, I want to get back to what you said about the Cigna. You said Cigna will allow you to bill one of two ways. So the one way you mentioned, like, just the one way. They just let you bill the way. Okay.
There are two ways to bill it. Cigna and Aetna both want you to do it where you provided the service, even though it was your supervisee. Other companies do it the way I consider correct. And the way, if you really were doing incident to billing, like with Medicare, this is how you would do it. And it's box 17 in the 1500 form. You use a qualifier DQ, and I just try to remember Dairy Queen. And then you put the name of the supervising. DQ says supervising. Then you would put your name, Kim, your NPI. And then box 24J would have the name and the NPI of the actual rendering clinician who is the provisional licensee. And then it would be your group information down in 33. And that is like the right way to bill it. But not all insurance companies want it that way. And the reason is, get this, they don't want to have to roster the supervisees. Meaning, meaning they add this person's name and NPI to your group. It's not really
Right.
credentialing. It's sort of a credentialing function, but they just don't want to have to bother with it.
That's obnoxious.
It is.
And that leads to the next problem, right? That we see in this population when you're trying to like, do a good thing and still bill and try to help these clinicians and all that stuff. There then becomes this lag time, right? So the clinician, you're billing under this supervisory provisional licensed rules, you're following all the rules, and then they get licensed, right? And then you have to credential them. And then there's a 90 to 120 day window where maybe, I mean, if you got a roster, I guess it goes a little quicker, maybe. But this 90 to 120 day window where I can no longer bill this way and I can't, like, they can't really bill for themselves because they're not fully credentialed yet. So what do we
What do you do?
Yeah. What's your, like, do you have a workaround or like strategies or
That
tips or anything
really
for that?
depends a lot on state law. And I really
Okay.
think the states are, as a general rule, starting to step up. I was just talking yesterday to a group practice here in Washington, and we are so lucky here because it's in our state law, and it has been for a number of years, that if you are a group with an established relationship with an insurance company and you file a credentialing application, let's say I join Kim's group and Kim files for me because I got my license today and she had everything ready. And then when the board, gave me my license number, she pops it in and hits submit, then it can take 90, 120 days. But the law says my contract effective date with your group is going to be today. And so you can
Nice.
back bill, which, yeah, during the interim, you still have to, I don't know, either hold your billing or bill out of network and then adjust. However, in Washington state, some of our payers are a lot nicer. Timely filing isn't 60 days, it's a year. So that helps. Nationally, not all states are so lucky. States, I think,
Yeah.
need to put that into their legislation. If your state's law isn't as kind, I mean, and this has opened the door for another big topic, the platforms.
Yeah, I want to talk about that too and hear your take on that because I know you did. We're talking about like Headway,
Yes,
Alma,
yes,
Grow,
yes,
Sondermind, all of
all
that.
of
Yeah.
those. And I get why clinicians feel like they don't have a choice because they kind of don't.
Yeah.
And
Yeah.
I don't judge the clinicians for making the choice that they're forced into making. I judge the billionaires that have set it up that way. However, there is another option. The problem is it's exhausting and time consuming. And that is the
Yeah.
No Surprises Act allows for continuity of care.
Okay.
Continuity of care says you get up to 90 days when your clinician is no longer in the network. Well, your clinician who was supervisory billing, your provisionally licensed clinician was kind of in the network via supervisory. Now they're not. They still qualify for continuity of care for up to 90 days. And then after that, you can typically get a single case agreement for the rest of the credentialing on the grounds that you're in credentialing anyway. But the problem is, okay, you've got a caseload of how many, and you've got to do that for all of them. It's just, it's unworkable. It's a lot of work.
What a nightmare. So it's like researching this before you even decide to take this on, if you're a group practice owner, would be really smart. Or meet with Susan and like say, what do you know about this state and this insurance company and what should I do? And give me the roadmap to make sure I do this correctly so I'm not stuck, with these clinicians
Right.
that their clients can't see them and we got to find new providers or we can't bill and we're out of money, that whole thing.
Right.
Yeah.
And in some cases it's already, I mean, we've always been in healthcare in this country, a society where haves, have nots. It's sort
Yeah.
of also because most state Medicaid plans allow supervisory billing and have done for years because they pay so little in most cases. What happens is the supervisees get a lot of Medicaid clients, and I'm not saying that that's bad. I mean, a lot of times a fresh clinician who's not dealing with burnout and really eager to learn is going to be a really great clinician, but it's still a segregation kind of.
Yeah.
thing. Yeah. And then
Yeah.
when the clinician gets licensed, okay, they've got their student loan payment, they've got
Oh my
a million bills, they've got to earn a living, and now all of a sudden the Medicaid reimbursement rate, especially when you're working for a group and the group is taking a split, it's not that great. So what happens? Your wonderful, eager new clinician is like, I'm sorry, I can't afford to see you anymore.
Right. Yeah. Or I've got to go out on my own. I can't work for this practice anymore. Right. I've got to take you with me or get credentialed separately.
Right.
It's like a whole thing. Right. Oh my goodness.
Yeah.
Okay. So let's talk about the platforms for a minute. Maybe you could just, I know that's a whole nother, like I said, we
That's
need
a whole other-
17 episodes.
That's a whole other podcast.
Could you touch on, so when we say platforms, we're talking about Headway, Alma, Grow, Sondermind, all of these like venture capitalist platforms that will credential you, they'll bill for you. You just kind of show up, see your clients, and they do the rest for you. What, like, what do you mean when you say like, of course, clinicians are doing this. It's like what you need to do because otherwise you're screwed, kind of like what you didn't say that. That's my paraphrasing.
Well, no, I'm trying to keep my language clean.
Okay.
In some areas, to be perfectly honest, let's say you are supervisory billing. You're billing for me. I get my license, and then I want to join that same network. In some areas, clinicians are now being told, nope, the only way you can join is through Headway. You can't join independently anymore.
Right.
Step in the door. So now what? What are my options if I want to keep seeing these clients? Bill through Headway.
Yeah.
But, I mean, unless they can afford to self-pay, which that's a shrinking population right now.
Yeah. And why would you if your insurance covers therapy? I mean, that's a
Exactly.
whole other thing.
You're paying so much for your insurance.
That's true. And, I saw a graph the other day. I can't remember where I saw it, but the insurance companies that are associated with each of the platforms, like they're part owners
They are
in the
investors
platforms
in the
now. And I can't
platforms.
remember who goes with who, but
I document it in some of my blogs. I try to keep current on it. It's a moving target. There is, I think, one of my recent newsletters has a link out to somebody that's following it even more closely than I do, and it all shows the interrelationships. It's very sick. And then there's a whole generation of up-and-coming platforms that you've never heard about that just feature like one specific, like there's eating disorder, there's a couple for kids, there's substance use. Then there's something called Interwell, which
I haven't seen that one.
that I was like, how could that even be safe? Because what it is it's ketamine assisted through telehealth and at a distance. I'm going, how is that even safe?
Wow. Yeah.
Yeah, and it's a platform.
Interesting.
Yeah. And
I hadn't even heard of that.
what's also making me just crazy is, you know how they talk about all the time, like they want medical behavioral integration and how that's a great thing. I think it's a wonderful thing. You know why it doesn't work? Contracting. Because credentialing and contracting, because behavioral health is still segregated. I'm sorry, what was that about mental health parity and not discriminating or segregating? It doesn't seem to apply to credentialing and contracting. That needs to be addressed legislatively on the state level until we can get a federal government that's going to pay attention to this. The other thing, though, is that the model that I like is called COCM. I'm forgetting the acronym all of a sudden. But anyway, there are platforms now devoted just to COCM. And it's so hard to get contracted for that because of this divide between medical and behavioral.
I know you don't know the acronym, but what is COCM?
COCM is a really good model. And I'm going to talk clinically again.
Okay.
And I think clinicians would love it because it takes all this administrative nightmare off of their plates. If you can get together with a primary care physician, not a psychiatrist, a primary care physician, and work with them to set up this, it's like a triangle. You've got the primary care, and the whole rationale here is that primary psychiatric medications are much more prescribed in primary care settings than in psychiatry, because psychiatry nurse practitioners are so few and don't take insurance. So it's a triangular model. You have the primary care who owns, I guess, the patient. Then you have a psychiatric consultant who is a psychiatrist or a nurse practitioner. And then the therapist, psychologist or master's level, or even provisionally licensed.
I was going to say, could you bill incident 2 then?
Yes.
That's incident 2, right?
That's incident 2.
Okay. Yeah.
You are the case manager, but you can also do therapy with this person. And it is all managed by the primary care office and billed by the primary care office, which means it's incident 2 and you're getting reimbursed more because it's going through a medical.
Right. Higher rates.
So,
right.
But trying to set that up from our end
Yeah.
is almost impossible because of the segregation of credentialing and contracting. So guess who's coming into this? The platforms. And now I've found platforms that you want to do COCM. Oh, sign up with us.
I have not even seen that. That's interesting.
I'll have to get you the names. It's in my kind of
curious.
ever research. I've got this research file of emerging platforms and who invests in who. And yeah, I mean, Cigna even owns outright a platform. It's called Octave.
Right.
They even own one, and then they invest in, I think, Headway and maybe Alma. I don't remember the specifics, but
I think so.
Yeah.
I mean, it's like that has to be illegal. I mean,
it's
right?
not,
It's like,
unfortunately.
You would just think that, I don't know what you would call that, but like antitrust laws, or, I don't know what that is, but it seems
Don't
like
even
it
get
just
me started.
doesn't make sense. Okay.
It's like we're told that you and I can't converse about rates because we're somehow colluding, and like
Right.
like that's going to make a difference if people on your Facebook page talk about rates, like that's somehow illegal. But this whole platform thing, and this gets into another big area of mine, which is price transparency.
Yeah.
There are tools where I can find out when anybody is reimbursed by insurance, down to the tax ID and NPI level. And I have the tax IDs and NPIs of Alma, Headway, Brula, blah, blah, blah.
Whoa.
And I know what they're getting paid. And here's the
a lot.
And here's the thing. What they're getting paid is a heck of a lot more than what you're getting paid.
Right.
They may
That is
add
true.
like $10 more than what you would be paid if you contracted independently, but I've seen them making a lot more. And here's the thing. If your client has a deductible, your client is paying what they're making, not what you're making.
Right.
And
exactly.
honestly, it's legal money laundering because they're taking the money from Blue Cross's pocket on the right hand and they're putting it in Blue Cross's pocket on the left hand, and then they're kicking a little to you for your trouble. And it should be illegal, but it's not. Not yet,
It's just
anyway.
so crazy.
Yeah.
When you really start thinking about it. Oh my gosh.
It's disgusting.
Okay. So, do you want to tell us that tool, or is that top secret? Is that
Well,
like
it's not
just
top
your-
secret. The problem is it's extremely pricey. I
Okay.
subscribe to it, and every month I go over with my accountant because it's about $2,000 a month.
Oh,
Which is
Your
why I
accountant's like,
charge
why
what
are
I
you using
charge
this?
for price
Is it worth
transparency
it?
data dips, because
I love that.
I have to, I call it PTSDD, price transparency strategy data dive. And so
love
I
it.
sit there and I meet with you and you tell me your goals. Who do you want to
Okay.
get a better rate from? And we do a deep dive into your market and I advise you on the feasibility. And then we craft like a customized rate increase letter, which does a heck of a lot better than a template. Dear insurance, I deserve more money because blah, blah, blah.
I make this much, and
Yeah,
the going
okay.
rate is this much, and
I know
and I
what
have
works.
all this trading.
I know what works.
Yeah.
I have the statistics and the research, and I make it very research based, and that's what they eat up. And so I've
That's
been
awesome.
able to do better than average. But then there's times when I look at the data and I'm just like, it's not happening for you. It's just not going to happen.
Yeah, it's
But
not a thing.
At least you know.
Yeah,
And don't beat your head against the wall, and you can look at other options for your practice. You know.
amazing.
Yeah.
Or like D panel, like this is what I'm never going to get a raise from. Maybe I need to get off this
Exactly.
panel. Maybe that makes more sense.
Exactly. Yeah.
Yeah. Wow, that is so cool.
Yeah.
What an awesome service.
Yeah. That is one that's becoming ever more popular. And so, but to get
bet.
back onto the policy level, it's like your question about how is this legal is like, so in in an era where price transparency is a thing,
Yeah.
like, how is it that we can't share rates? And I've pretty much figured out that the sharing rates is not illegal. It's the, all right, let's get together and boycott Cigna until they pay better rates. That's the illegal part. But then again, they're still, colluding.
Right.
I mean, they collude through CAQH. CAQH is all owned by the payers.
Oh,
I mean, the board of
gosh.
directors
Yeah.
reads this insurance company, that insurance company, the other insurance company.
Oh, my God.
And CAQH has other tools that people don't know about. For instance, you know how you get these clawbacks 2
Yeah.
years later? Oh, I'm sorry, this person really had Aetna primary, and so United is clawing back the money and now go bill Aetna.
Yeah.
The tool that they used to identify that was invented by CAQH, and it's a subscription tool that the insurance companies have. They all share their data of who's insured, and then they go query it via like an API after a certain length of time, and then that's how they know to claw back from you.
Oh, my God. That makes me want to puke.
Yeah.
Because then you're out of the timely filing window, right?
Oh, it can
Or
be. It can
you
be disputed.
Can
but,
you still? It can be disputed.
Oh, it's
Okay.
absolutely
Wow.
disputable and winnable. But the problem is they're counting on you not, because it's a lot of work.
Right. Right. And that's where you come in.
That's where I come
Yep.
in. Yeah.
I love it. Oh my gosh. Thank you for being here. And tell people where to find you. How do they work with you? When's your training and all that good stuff?
So psychbuildingcoach.com is the main website. There's a lot there, a lot free. I have a newsletter. I try to keep people up to date on what affects you. I try to, if we're possible, report good news as well as bad news. Congratulations to, let's say, Illinois, because in Illinois, it's a new state law, January 1, 2027, 141% of Medicare guaranteed for Illinois clinicians. That's a huge jump.
Oh,
And the
that's
insurance
amazing.
companies are already circling the wagons trying to find a way around that, and I'm probably going to be reporting on that here shortly. So psychbillingcoach.com, there's a free newsletter, free blog, I have like a news blog as well as like a blog. And the difference is kind of, one's more my opinion and more in depth, and one is more just, all right, Dr. Oz said that, Medicaid is going to be revalidating. So here's what you need to know, and much more factual. And then hit on schedule, and you can schedule a consultation or the price transparency session, or my tool that you mentioned. It's not like your tool. Your tool is more like billing 101, like getting people into it. My tool is a little harder, and it's still not done after how many? 2.5 years, because I'm literally
It's never done.
Well, it's never done, but it's not done. But I'm literally building a resource of everything you need, so that if you want to know, hey, does Blue Cross of Texas allow supervisory billing, you can come find it. Or, hey, can I charge a no-show for TRICARE? Or how do I credential with this or that? Or what's the deal with this, like, Champ VA? Just all those rules, manuals, like one place where you can dig into it. But I am not AI. I'm only using AI to find the citations, and then everything else is, infographic done by me, video done by me, text written by me. And I have no venture capital funding either, so I have to earn a living. So that's why it's going really slowly. But I'm about, I guess, 65-ish% done, I think. And so I do have beta subscribers, and that's what it is. And there's a lot of like form templates and things like that I offer as well in there too. So, and subscribers get 15% off of everything else that I offer. So that's kind of my services in a nutshell.
I love it.
Yeah.
Thank you so much for being a guest today. And of course, we're going to have you back for some of these other topics. I'm sure people are going to be like, but you didn't talk about this enough.
Right. We
So we'll have
touched
to
on
come back
so
to-
many things.
Yeah.
And I forgot to mention, I also give webinars once a month. They're generally on
Oh,
Fridays,
nice.
Friday mornings, about once a month. The one in July is going to be on supervisory billing.
Love it.
Yeah.
Yeah. And we're going to have links to all of that you guys can check out in the show notes. And thank you. Thank you
very
for being
welcome.
here.
Thanks
This
for
is
having
so
me.
helpful. You're going to save a lot of people from a lot of pain, by just
the goal.
suggesting that we research this stuff ahead of time.
That's the
Right.
goal. I know I'm weird. I like the research. And you don't
It's
have
great.
time. You don't have time to research.
Yeah. And we need people like you. Your blog is amazing. I've looked at it many times.
Thank you.
For different, because the SEO is so good. Anytime I type in a search, like your blog pops up. It's really great. So
I'm going to tell my website person that because she
tell
that
them,
will make her
for
day.
real. That's happened multiple times. I mean, I think that's the first time I ever heard of you, was just like randomly finding one of your blog posts about something. I don't remember what it was. It was something with Medicare probably.
Yeah.
But yeah. So thank you for everything that you do.
Oh, you're very welcome. And thanks again for having me.